Thank y'all. It's good to be with you this afternoon. I'm going to talk about some of the new revolutionary technologies that have come to our placement in our field, cardiology. I'm going to talk to you about a quick review of the heart in 60 seconds, so we all be honorary cardiologists for the afternoon. What are the disease states of cardiology? Well, they're essential several. So if you have heart disease, that's cardiac related, obviously, in heart. It can be coronary. You can have blockages in your heart. You can have electrical problems in your heart. You can have structural problems. The muscle can get bad. The valves inside the heart can get bad. So we're going to review some of those today. What are our new advancements? I'm going to highlight 3 that have come really along, 2 in the last year, really some in the last couple months, and then one that's been worked on for about the last decade. So if you are thinking about healthcare, you can be not just a physician. It takes a big team of people to be in the healthcare environment. It takes administrators, it takes staff, technicians, it takes providers like myself, and you just have to figure out if healthcare is appealing to you, where might you fit into that paradigm, in that model, because there are plenty of opportunities to affect patients and our healthcare at large. So for me, the timeline to MD was long. I was 30 years ago, I was sitting at Hammond, like you guys are today, and 12 years at Hammond, followed 4 years of undergraduate school, 4 years of medical school, 3 years of residency, and 4 years of fellowship. So after 12 years at Hammond, I wasn't quite halfway through the journey. So it's a long journey to get sometimes to places. So, but it's a fun career. So this is your heart. There's 4 different chambers. So you have 2 uppers and 2 bottoms. So it's pretty simple, right and left. This is your left atrium. This is your left ventricle, right atrium. Blood, deoxygenated blood comes in through the right side and goes out through the pulmonary valve to your lungs. It gets oxygen stuck onto your blood cells, and then all pours back into the left atrium, and then shoots out the left ventricle into your aorta and out to your body. That's your heart in 20 seconds. The heart is surrounded by arteries, so this is what I like to do. I'm an interventional cardiologist. The arteries are your blood supply to your heart muscle. So many times heart disease, if you hear somebody with that, is the biggest leader cause of heart disease is coronary artery disease. You get a blockage or develop a problem in the flow in one of these arteries. But you also have valve problems. So you have 4 chambers, you have 4 valves. Valves are like the doors that let blood in and out of your heart muscle. So you have a mitral valve, a tricuspid valve, aortic valve, and a pulmonic valve. Again, both allowing the directional blood flow in and out of your heart muscle. So the PCI, this percutaneous coronary intervention, that's what I do on a routine basis, has been quite a journey. So back in the 80s, it's going a little bit off the screen, but all we had was POBA, plain old balloon angioplasty. So if you had a blockage in a heart artery, we put a balloon in it and then pray. We inflate the balloon and pray that everything was going to be okay when we deflated the balloon. But oftentimes the artery would misbehave and it would collapse right back on itself, and you put the balloon back up, leave it there for a while, and then pray again that when you deflate the balloon, everything would be okay. But often the case was that people would be sent emergently down the hallway to have emergency bypass surgery because the artery just would not behave and wouldn't stay open. So we came along in the 90s with stents. So stents are metal frames that help scaffold the artery open. So when you put the balloon inside the stent, you inflate the balloon and the stent gets expanded inside the artery, and then the artery can't collapse again, right? So you put a piece of metal in. Well, now we have 2nd generation stents. So these are called drug-eluting stents. So oftentimes the stent would sometimes incite trauma because we're inflating traumatically inside the heart. The artery reacts to that trauma and sometimes causes it to reclog back up. Now these stents have drugs that are on the outside of them that helps your body not have this aggressive adverse response. And where we are today, we're in the newly released fully absorbable scaffold. So it's a stent that actually is absorbed by your body over the course of time. It's quite a remarkable pathway. It's been taken about 10 years for it to evolve. So if you put a stent in, like this is an artery. We like a little skin to develop around the stent so that the stent, if you took a camera inside the artery, you wouldn't even tell where the stent was because there's like a little skin cell layer that covers the stent. But sometimes that doesn't always happen. You may have a piece of the metal frame that's never fully covered. That can lead to leg problems. You can have plaque that develops outside of the stent. And then you can have what I alluded to earlier, is that the vessel just traumatically incites this growth inside the vessel, and it narrows the vessel back up. And then you can have maladaptation to the vessel as the traumas happen. So these metal stents that we put in routinely are very good. They help tons of thousands of people daily, but sometimes they can lead to late-term events. So we're always looking for a next cure. And those stents have metal. You're always going to have a permanent implant, and that, it's going to be there with your life forever. And we don't like to necessarily want to have something in there forever if we can help it. So it can create artifact. People don't want a permanent implant. You can't get past it sometimes through little side branches that are there. And so we've got some new data from this new absorbable stent that can maybe over the course of time not have this adverse pathway. This is 5 years out, that kind of plateaus as the stent inside of you is healed. So this is again the principle. So if you're an orthopedist, you put screws and all that in your bones. Probably some of you guys have had that happen to you. So now we use plastic screws that actually absorb into you. We use suture material that absorbs, and now we have stents that are absorbable. This is made out of essentially starch, just like cornstarch. So it's polylactic acid that is cut just like any other stent. It's the same model. These little stent cells that allow us to expand the artery. So this is the time course. So we put a stent in. It has a little healing process over 3 months, and then 3 months to really 9 months, the stent starts to get absorbed by your body. And then over 2 years, it's completely absorbed and replaced with a little neointimal structure in the wall of your artery. So pretty neat pathway. So this is what a stent inside an artery looks like. So this is, you see these metal frames that are into. This is a gentleman that had multiple stents over 10 years. But this is what a bioabsorbable scaffold would look like. Same artery being fixed, no residual. That's the principle. So these stents, again, are comparable to what we have best in class with the giant struggling stent. This is what a stent artery looks like. So this will play for me right here. So it's playing sideways, so just kind of your head to the right. So the vessel is right here. This is a gentleman with a bad blockage right there. You can see where the artery is blocked. And then this is just another view of the artery blockage right there. This is the artery being fixed with a stent. This is the stent scaffold on a balloon. That's it going in the vessel. And this is just another view of it. And then this is what it looks like now. So where there was a blockage is no longer there. And you don't see the stent, the metal frame that we typically see when we fix arteries in coronary world. You see. So that's stents and stent technology 101. So the second part that can go wrong with your heart is the electrical problem. So we're all sitting here today because our hearts are beating at a certain rate. And so we all have these little cells called sinus cells that are in our hearts that tell us how fast and how slow our heartbeat should go. So some people have an abnormality with that. The pacemaker gets sick, and they end up needing a permanent pacemaker implanted to take over this work. Well, this is an example of an electrical phenomenon. So this is the heart being beat, and then all of a sudden you see no beat, that's asystole, and then the heart picks back up again. So that's a gentleman who needs a permanent pacemaker put in to help take over that electrical need for the heart to do its work. So this is the advent of pacemakers. So this gentleman had 1951. This is where we were. This man had to be plugged in and wheeled around the hospital permanently to stay alive. And this is the machine that sent out that little electrical signal to his heart to tell him to beat. Well, they got much smarter by 1957. They had it sized down to this little capacitor that would tell the heart, and then these wires would be inserted, and again, it lasts for like 6 months, and it'd have to be replaced. We've come a long way. This is what's typically put in. So this is a pacemaker that goes underneath your collarbone over here on your left side. It goes through your vein into your heart. And these little wires are positioned under X-ray to provide a signal, a little electrical impulse for your heart to beat at a certain frequency or time. This is what it looks like under X-ray right here. So now we've come up with another generation, and by the time you guys, if you go into cardiology or medicine, you'll think this will be even smaller. But this is the new MicroPacemaker. So this is about the size of a bullet, 22 caliber bullet, that goes into the heart muscle to do that job. So that's compared to a dime. This just got released within the last 2 months. We did the first one at our hospital in the state about 2 weeks ago. So it's just an exciting time. So this is a catheter. So this is a tube that we put in your vein, runs the tube up towards your right side of your heart. It dips down to the right ventricle, and this thing is buried into the wall of the heart muscle. And it's got little tines on it that are, this is under x-rays, this is the catheter. It drapes itself down into the heart, and then we press it into your heart muscle and then release it. So this is kind of a little capsule form. It's got little tines that dig into the heart muscle and get trapped underneath there. And if we're comfortable with how well that device has been trapped inside, then we cut the little tethers, the little dental floss that's attached to it, and we let it free. And so this is what it looked, hers looked like after we left it in place. So again, no lead up here, no permanent device. This little battery will last 12 years. Pretty incredible, right? So you imagine your cell phone requires 24 hours and it's dead. This little battery that's inside this device will last for 12 years, which is pretty incredible. So our third topic today is aortic stenosis. So this is another big transformative therapy that we use in our patients again every day. And this is called aortic valve stenosis. So this is the structural part. So your valve, again, on top of your heart, fails to open. This is the aortic valve that you might be born with that's abnormal. This is what Arnold Schwarzenegger had. This is one that's been diseased by rheumatic fever. Not usually a big problem in our country, but in India, this is still a big player. And then obviously just seeing how you get older and your valve starts to degenerate, just like, say, an arthritic knee would degenerate, that the valve doesn't open as freely as it once did and gets restricted. So this disease is a terrible one to have. It's almost, if you have the aortic stenosis, it's like having essentially terminal cancer. So if your survival rate is 50% at 1 year without a new valve, so it's a terrible prognosis if you do acquire aortic stenosis. This is the old way of fixing the valve. So the surgeon would open up your chest, correct the aorta, we'd cut out the old valve, and then put a new one in under surgery. You see all the sutures, and you kind of glide it into place, and then you cinch it down, and that's your new aortic valve that's been put in by this picture. So what about another way? And so a lot of our patients, well, they get to a point in life where they're too sick to go through major heart surgery. So we can fix the valve, but just on the back end, they wouldn't survive the rigors of surgery, because it's a very rigorous process to go through. So this is Dr. Grunzig, who's from Germany, and he's really the grandfather of interventional cardiology. So he's the first one who came up with balloon angioplasty, and he also thought about aortic valves. So this is the gentleman, we did the same thing for valvuloplasty, was what this is called. In 1988, we did the first valvuloplasty, and I'm not sure this is in play. So, sorry. That's going to play. But anyway, this is where your aortic valve lives, and we put a balloon inside, and then crack the valve open. But unfortunately, just like any other artery, it will collapse back on itself. So we've come up with a stent valve. This is called TAVR. You've probably heard this maybe in the lay press, but this is a valve that's sewn inside this little stent frame that then gets deployed across the heart muscle, across the aortic valve in this plane. So this is we're now 16 years out. This is the first one done in 2002. You can see how scared these guys look doing this. But this is the valve that's on a stent being expanded inside this gentleman's artery. So this is how we do these procedures. Let's see, is it gonna play? Okay. So this is all done through a catheter. A catheter is a tube that we deliver a therapy through. So this goes up from your femoral artery through your aorta, and it's going to retroflex back. There's the sick valve. So we put a wire past the aortic valve as your heart is beating, And this is the sheath. It's a large sheath, and that's what's really happened in the last 5 years. That the sheath has gone from something the size of your thumb to something about the size of a pen, like a writing pen. And this is the valve being inserted, so we put it across the valve. This is the balloon. We expand the balloon, deflate the balloon. That balloon comes out. Now we've got the valve a little bit more compliant, a little bit more flexible, and now we're putting in the transcatheter valve. Here it comes. There it goes. This is the valve with the stent around it. We just have to position it correctly inside the balloon inside the stent frame. Cinch it down, and then we advance it across the stick valve. The heart's beating. Again, all done through a little catheter. And then the balloon goes up here. The stent's expanded. The balloon comes out. The new valve is working in place. And everything is now removed from the body. And the new valve is in order. So and that relieves the burden for the patient in a fantastic way. So this is, again, a picture of a schematic of that. This is what it looks like under X-ray. This is what we see. We don't see that pretty 3D image. This is the picture that we're working in. So that's a quick review of cardiology. I think that my field is exciting. I love the technology. I love the physiology of heart work. Thank you guys for your attention today.